Welcome CTSNet friends, my name's Joel Dunning here with another edition of the CTSNet Beat podcast. This is an absolutely packed edition. We've got some really interesting data on what happens if you just watch an ascending aortic aneurysm. We've got AR in TAVR complications. We've got how well does a patient recover after esophagectomy. We have some stellar videos for you. These really are do not miss videos. An incredible, beautiful robotic mitral after previous MitraClips. We've got a really clever way to fix some pseudoaneurysms in the aorta and a paravalvular leak. And for those trainees amongst you, there's some beautiful videos all about hiatus hernia repair. We've got a shout out for Diego and honourable mention, so let's get started. Thank you for joining us again for the CTSNet Beat podcast. My name's Joel Dunning, and the whole reason we do this podcast is keep you up to date with everything that's going on in the world of cardiothoracic surgery. So today we've got 3 news items and 3 fabulous videos and also some information about what's going on in the next few months and some honourable mentions. So we'll get cracking with the news items. So the first one we picked out for you I think is really interesting. This is the fate of the unoperated ascending thoracic aortic aneurysm. 3 decades of experience from the Aortic Institute at Yale University. So Jinlin Wu is the first author and the senior author is John Eleftheriades. And certainly myself as a cardiac surgeon, when I was seeing patients with ascending aortic aneurysms, they would always ask, what is going to happen if I don't do anything? And, I always struggled a little bit to really have the data at my fingertips, but this paper just out really gives us the answer, which is fantastic. So they have 964 unoperated ascending thoracic aneurysms that they have been following up with their Aortic Institute. That's a huge number of non-operated aneurysms. So what they do is they look to see if they have an adverse aortic event. Now that's a dissection, rupture or aortic death, and they've followed them up at average of 8 years, but actually all the way up to 34 years. And they've subdivided these. These are non-Marfan's patients, basically. This is sort of, your bread and butter patient with an ascending aortic aneurysm. And they've broken up the sizes all the way from 3.5, hardly large at all the way up to bigger than 6 centimeters. And they've looked at the adverse aortic complication rate. Now, when it's small, when it's 4, when it's 4.5 and 5, the adverse event rate is 0.2%, very small, 2 in 1,000 per year. But as you start to get above 5 centimeters, that curve started to really rocket up, and they produce a beautiful curve that really shows that rocket up point, where does it start? It starts at 5 centimeters, not 5.5 centimeters. So as you get to 5 to 5.5 centimeters, that's where things start getting a bit higher risk. The risk becomes higher than 1% a year, and then at the very highest risk category, your chance of something terrible happening goes to 3.5% a year. And that they actually give an argument that actually maybe we should be a bit more liberal with how we recommend surgery. We shouldn't wait till 5.5 centimeters. We should go to 5 centimeters, which I think is really interesting. Now, one of the other things that I took away from this paper was that aortic aneurysms don't suddenly get bigger really, really fast. They showed that they expand at quite a slow manner, 0.2 centimeters a year. It was very rare to see any going bigger than 0.2 centimeters a year. So if you're seeing somebody with an aneurysm and they don't really want to have an operation, you can be pretty reassuring to them to say, look, we'll check it again in a year. It's not going to expand all that big. And actually, even at that highest risk category above 6 centimeters, I guess 3.5% risk a year, isn't the world's biggest if, say, you're 85 years old or 90 or got lots of comorbidities. The other really nice thing they've done in this paper is they've produced a beautiful risk graph, which is 3D because it's stratified by age as well. So they've got the size of the aneurysm, they've got your risk of an adverse event, but in a 3D way, they've got your age, because the older you are, the higher your risk is of something happening. And I could really see myself showing that to a patient just to give them a really nice graphical illustration of the risks of not doing anything versus doing an intervention. So great job. One other thing I really liked was that this paper in the Annals of Thoracic Surgery had an audio abstract, so you could just click on it and just have a quick listen to what's contained in it. So if you're driving home today and you just want to click on something and listen, have a little look at that. Great job, guys. Really well done. So the next news item we picked out was something quite interesting, I thought. The title of it is Artificial Intelligence Predicts the Likelihood of Common TAVR Complications. This is a paper by Pradyumna Agasthi and Reza Arsaniani from the World Journal of Cardiology. They're from the Mayo Clinic Phoenix and they're cardiologists, and they took a huge database of 1,200 patients undergoing TAVR. Now, in their database, we all know that there's a very high permanent pacemaker rate in TAVR. In their database, the permanent pacemaker rate at 1 year is 26%. At 13 days, it's 20%. So 1 in 5 to 1 in 4 are needing a pacemaker after TAVR. And they were asking the question, sort of, how can we predict which patients might get a pacemaker? There are 1,200 patients, as I said, and it's a 5-year database. But the reason we picked this out, the reason I thought this was really interesting, was their use of AI. Now, I don't understand all the clever stats on it. They used a graded boosting model. I don't know what that is. But the thing they did is they just put everything into their computer. So they didn't just go, age, gender, creatinine, all that sort of thing. They put absolutely everything in. And they got some really interesting things out that were predictive. So the number one predictive thing was the distance from the right brachiocephalic artery to the aortic annulus as a ratio of that with the patient's height. Now, I wouldn't have even thought of that as a criteria, and yet because they put everything into AI, the AI has been able to generate that as a really important risk factor. So other risk factors were right bundle branch block, self-expanding valves, the mitral E-wave peak velocity, so mitral regurg, body mass index. So, but they picked out some pretty interesting things. A left atrial volume index came out as predictive. And when they put it all together, their area under the curve, their ROC curve, was 0.7 versus 0.5. So it was really quite predictive. So what did I learn from this? Well, what I learned from this is actually if you try and take all your data, if you've got really, really good comprehensive databases that we do these days, if you put it into AI, nowadays it can actually tell you factors that you maybe hadn't thought of. And I think that's a really interesting finding. So perhaps combined with this risk model to be useful, to predict people that's going to need a pacemaker, maybe you could put a loop recorder in straight after your TAVR for the higher risk people, or maybe we're even going to look at extended sort of observation for these patients, if they're high risk in the model. The actual wider picture of using AI for risk prediction, I think, is something very interesting and exciting for our specialty. So well done to the team there at the Mayo Clinic Phoenix for writing that paper. The third new scan paper that we have picked out for you is a really nice one by Alicia Bonanno and Onkar Kalua from the Emory University in Atlanta. And the title of this is The Recovery of Patient-Reported Quality of Life After Esophagectomy. I think as surgeons we are quite focused on getting them through the operation, getting them out of hospital, and if they survive, we're done, job done. But actually, more and more, and certainly in the UK, our major research funders are very laser focused on patient-related outcome measures. And this brilliant paper that has just been published really concentrates on quality of life. So they use the National Institute of Health sponsored patient-reported outcomes measurement information system. So that's collecting a large number of data on physical function, on pain, dyspnea, and they used it in their esophagectomy patients. They collated these to find out how did they do in a 3-year analysis. So now, another important thing is that not all these people had malignancy. So 87% did have malignancy, but some were achalasia, strictures, dysplasia. So it's really important when you're doing benign surgery as well to really think about their quality of life. But obviously a lot of them were for malignancy. But what was the findings? Well, the findings were that up to 50 days, really the patient-related quality of life was very significantly declined by 30%. So that's at 50 days. That's nearly 2 months out. They're still really struggling, and actually it took until about 100 days before the physical function scores were non-significantly different to preoperatively, but they were still 10% down. 100 days, that's 3 months later, our patients are still not back to where they are. And I think this is really important for us to think about as clinicians. Certainly ourselves in our hospital, we've really got a surprise of how long it takes for a patient to recover. We've just recently started a program of our staff on the ward now have a car and go out and see our patients 2, 3, 4 weeks after surgery. And we find they're not just cured, they're not fixed. And we actually put some motion monitors on them as well. We all expected that as soon as they get out of hospital, they're going to start rushing around doing everything. They walk less the first day they got out of hospital than when they were in hospital. Basically, a load of our patients are sitting at home, freezing, blind, terrified that they shouldn't do anything. All their family are running around them, doing absolutely everything for them. And actually, they're taking a lot longer to recover than we think. So I think this is really important. I think we should realise how long it takes for our patients to recover. This team have shown us that using the NIHR PROMS outcome measures, we can measure this. And so I think we really should do that a lot more in our practice. So well done, team there. And certainly challenge you. Do you collect your patient-related outcome measures? Maybe you should start. Maybe you should ask as a research project to ring people up at 30 days and 60 days to see how well they're recovered. Because I think it is really important. We no longer should be thinking, can we just get them to survive? Let's think, can we get them back to the way they were or even better? So those are our 3 journal and news scan items. Check them out on the CTSNet website in our JANS or in our weekly email blast telling you what's the latest and greatest of all our news scans. So now I'll hand over to Cameron Lind, who's going to tell you what else you can see on our CTSNet website.
Take advantage of the features on your profile page to tell the CTSNet community more about yourself. Head to ctsnet.org/user to update your background, place of work, and contact information. When you're done, head to the Profiles page to stay connected with colleagues and learn more about your fellow CTSNet members.
So now I want to tell you about 3 absolutely knock it out the park, amazing, beautiful videos. If you've got just 20 minutes, just have a look at some of these. They are really of the very top drawer, highest quality. And the first one I want to show you is robotic-assisted mitral valve repair after a failed transcatheter edge-to-edge repair. This is being put together by Rishab Humar from the Cedars-Sinai Medical Center. And the wonderful editor-in-chief of the Annals, Joe Chikwi and Dominic Emerson, were, I'm sure, the surgeons or heavily involved in this brilliant demonstration. And if ever you needed a demonstration of the amazing utility of robotics in mitral repair, this is the video to show people. You know, it's just incredible to me that we're not all getting 100% behind robotic surgery, and I think 5-10 years, you know, it's going to be the default way of doing it. So this is, you know, a big shout out for robotic mitral surgery. Have a look at this. Now, what happened? Well, this is a really interesting case actually, and I think they showed a really clever pathway to getting this patient cured. This patient was only 38 years old. They had familial dilated cardiomyopathy, and they presented in a complete state, completely short of breath, atrial fibrillation, severe mitral regurgitation, P2 prolapse, but they had cardiogenic shock. Their ejection fraction was 24%. He was on inotropes. He had a balloon pump. He was in a complete mess, decompensated heart failure, and the extremely experienced team there at Cedars-Sinai felt that he was far too high risk to go for surgery. So As a salvage procedure, they went for a transcatheter edge-to-edge repair, and 3 clips were placed to get to only mild mitral regurgitation. And they followed this patient up, and to their credit, the ejection fraction did completely improve. It went all the way to 64% 1 month afterwards. So balloon pump out, inotropes off, got out of hospital, and a month later, brilliant recovery of the left ventricle. But after that, on follow-up, his mitral regurgitation started getting worse and worse. And after a discussion, it was decided he should have surgery. He was a very young guy. Joe Chikwi and Dominic Emerson clearly would want to repair this valve in this young person, but they had this big problem. They had 3 massive, horrible clips on the mitral. But this video shows just the most wonderful view of the mitral. It shows how useful the robotic instruments were in being able to tease open each mitral clip, being able to push off the leaflet without damaging it. And they prized out these mitral clips with brilliant accuracy. They then did a beautiful triangular repair, changing over to the intuitive scissors, and then they did their triangular repair. They put their annuloplasty ring in, and they oversewed the left atrial appendage. And they also, not shown in the video, did a cryo ablation as well. So really good job. You really should watch this video. It really is excellent, and I think they did a lovely job there. Really nice. So that was a really good video. Have a look, check it out on CTSNet. You can look at it on YouTube, on any of our platforms are direct from clicking the link in the show notes below. The second video I'd like to show you is by Adam Carroll and T. Reese, and is a really nice video from the University of Colorado. And they had a big problem. This is quite a patient. Listen to this. So this is a 60-year-old patient who, when he was born, had coarctation of the aorta. And he had a bicuspid valve. At the age of 10, he had a left thoracotomy and repair of his coarctation. So that went pretty well. But then 15 years later, at the age of 25, he got bicuspid valve endocarditis, and he needed a mechanical aortic valve and a mechanical mitral. So fast forward another 20 years, he's now 48 years old, and he develops a large aortic root pseudoaneurysm. They show us some beautiful 3D reconstructions. They've got some lovely views, but the team, and you can see on the video that you cannot tell, is the pseudoaneurysm hole, is it above the mechanical aortic valve, or is it below the mechanical aortic valve? And this was giving them a real headache. And then the second problem this patient had was that they had a mitral paravalvular leak as well. So there was a hole next to the aortic valve, there was a hole next to the mitral valve. Now, what I really like about this video, this is the tip-top best thing about this video, is the algorithm they produced to approach this patient. It is a beautiful graph of how to plan an operation. They basically said, our operative approach is going to massively change depending on whether the pseudoaneurysm hole is above or below the aortic the aortic replacement. And so they said, okay, well, if it's above, we're going to do a transfemoral approach to plug it, and then we're going to just use a transfemoral approach to fix the aortic aneurysm. That's it. Now, if there's a hole above and below, are the 2 entrances, okay, well, we're going to do transfemoral and transapical, but then we'll fix both pathologies. We'll fix that one in the mitral as well. Now, if the hole is below the annulus, then we're going to go pure transapical. Now, it was all mapped out, and I'm sure they had their team completely prepped, and what a great example of how to do preoperative planning. So in they went. They showed us this 6 centimeter aneurysm. They did an LV gram, nothing. They then they did an aortogram, there was nothing, and then they did a transapical puncture, and they did an LV-gram, and there was the big hole. They put a wire into the pseudoaneurysm, and they showed a big swirling contrast from below the aortic leaflet. And then they showed a really nice demonstration of putting an Amplatz device in. They put a 10mm AVP2 plug into the pseudoaneurysm, and then did another LV-gram showing complete fixation of this. They then had a lovely 3D TOE image of a big hole next to the mitral mechanical valve, and they put another plug in there, and a 4mm plug, and completely fixed, all fixed transapically, no bypass, use beating heart. Great job. Well done, team. Absolutely beautiful demonstration of what you can do with pre-op planning. So the third video we've got for you is robotic-assisted paraesophageal hernia repair with preoperative anatomy and technical considerations. This is an absolute beaut for trainees out there in the audience. Daniel Clunan has done this from the Beth Israel Deaconess Medical Center in Boston with Cameron Stock, Elliot Cervase and Amara Watkins. Great job. So they had a paraesophageal hernia, and the thing that's really nice on this video is just how they did a beautiful job of showing you stepwise of how they approach it with their robotic approach. They do a lovely, beautiful diagram of where they put their camera, just to the left of the umbilicus, where they put their 3 robotic arms. They've got 2 assistant ports, one 10mm, one 5mm. They use the vessel sealer to take the short gastrics and expose the left crus. They then do some really nice overlay of the anatomy, just to show you where the lesser sac is, where the crus is, where the spleen and splenic artery is. They then show you the right crus, how to get into the clear area, where the liver is, and then up through the right crus into the chest. They then pull down the esophagus really nicely, get 3 centimeters of it out into the chest. They then do some really nice sutures. They're using some V-lock, pleated V-lock, 3 sutures below the esophagus, some hints and tips about how tight to do it. And then the really nice thing is they didn't just give us a single video, because they've shown us the 2 ways to do a fundoplication. They've shown us the door method, and then they've taken a second patient and shown us their technique with the Nissan's technique. So absolutely stellar. Well done. Great job, team. I do encourage you to look at that if you are interested in hernia repair robotically. So those are our Jan's news items, those are our videos, and now I just want to tell you about a few really good upcoming events. There's a great event happening held by EACTS. It's the Fundamentals in Valvular Heart Disease. It's April the 25th to April the 27th. It's held at EACTS House in Windsor, but it's also online as well as in person. So this is a really great 3-day course all about aortic valve anatomy, mitral valve anatomy. There's actually some hands-on sessions if you can get there, but don't worry, you can watch it all online if you sign up. There's a really good international group. There's Gridal, there's Dr. Reza from Zurich, there's all sorts of people from all over Europe as the faculty, which is really great. So I encourage you to check it out. Go to the EACTS website and have a look for this course, Fundamentals in Valvular Heart Disease. And if you can't get there, it's all online as well. Obviously, you are all, I'm sure, looking forward to the 103rd annual meeting for the AATS, May the 6th to May the 9th in Los Angeles. So check out the AATS website and get registered there. And then the third thing I just want to let you know about is a really good course called the Annual London Core Review in Cardiothoracic Surgery course. This is the 12th version. You can just go to londoncorereview.com and just have a look at what they offer. They offer 80 lectures, they've got quizzes, they've got course books, they've got a stellar faculty, Jabreen El-Khoury, Tyrone David, David Taggart, Karen Redmond, amongst loads of others. It's 4 days, it's cardiac, it's thoracic, it's congenital, it's esophageal. So it's really designed for very senior trainees or new consultants or people doing exams anywhere in the world, really. The really great thing is if you can't go in person, it's all online as well. And at £585, I think it does represent pretty good value, really, if you're going to be doing some exams in the near future. So check it out, londoncorereview.com, May the 10th to May the 13th. So finally, we're getting to the near the end of our podcast, and we always have two little items. This item's called "Where's Diego?" Diego Gonzalez Rivas, the world's sort of best thoracic surgery, travelling the world to help people all over the world. He's got a foundation as well, so check out his foundation. But he was in Shanghai last week, and this week he's nipped over to Lisbon to lead a uniportal VATS and uniportal robotic course, 2 days in Lisbon. It was really nice. They provided it completely free online, so I dipped in and watched some beautiful operations. There's some cardiac surgery in there, some robotic cardiac as well. He actually designed the uniportal robotic thoracic technique with his colleague cardiac surgeon. So a little known thing about Diego, he does like to dip into cardiac surgery as well. And then that's not all he did this week. He nipped across to Madrid to do a uniportal robotic middle lobe sleeve lobectomy, where actually they had to cut into the B6 and the B7 to 10 and do a sort of three-way anastomosis robotically. Very impressive. Well done, Diego. And check out next week. Our podcast will tell you where he is in the world. And finally, as an honourable mention, I want to mention to you that our honourable mention this week goes to the Epitor database led by Marcel Dehan and the French Society of Cardiothoracic and Vascular Surgery. It's 20 years old today. So congratulations to them. This is a fantastic database. Over 100 centres across France have contributed to it. It's got huge numbers of patients. And when I was visiting Jean-Marc Bast in Rouen, I was really blown away by the quality of the data entry that they put in. It's really detailed. It's really good for robotics, but it's really good for VATS and open as well. They provided some fantastic data comparing those three techniques. So congratulations. It was used by Pierre-Emmanuel Falcoz to create the Thoraca score. So it's got quite a history. So that's our honourable mention this week to the French Society. Marcel, well done. And a really good example of the power of databases over the decades. So that's all for this week. Thank you very much for lasting to the end of this podcast. My name's Joel Dunning. And if you have anything really interesting you want us to feature, have you just published a paper? Would you like us to profile your video? If you have, drop us a line at CTSNet and we'll put you on our weekly podcast. So from me, thank you very much.